All right. Now I think we're back in action. Cool. All right. Fixing knee pain when squatting. I think we've all kind of experienced this, so this will be a really good overview of kind of where to start today. Just a beginning take at Thrive, especially, we have different kind of missions and values than to the typical PT place. I've seen it kind of all too going through school, but I think we really try to create a extraordinary experience for anybody coming in, doing that new standard of healthcare. A lot of the time you're going to go into a place, you might just get a few exercises, you hope it gets better, and through time sometimes it does, but we really like to excel that process and get you feeling really comfortable and back to the things that you love doing. So with that, it's healthcare reimagined, and we really want to drive home the idea that movement is key for a lot of people, and we don't want you to stop moving. So that's why we do a lot of these different kind of webinars or workshops, so that you can find what's right for you to get started. And if it's not right for you, you can always come see us. With that being said, a little bit of the agenda we're going to do is just anatomy overview, some causes of knee pain, kind of those diagnoses that fit in the box of maybe what's causing it, but then kind of what you could be potentially diagnosed with. A lot of the time we're trying to move away from labels of things, and we're kind of moving more into kind of the sources or those root causes of why the knees actually may be irritated. We're going to self-assess. So you could do this at home to see if you can kind of come up with a notion of what's going on, and then some starting tips to fix. So with that, the nice beginning, we have three bones kind of coming together. I'll point as we go, but we have that femur or long bone on the top, the nice tibia underneath, and then the patella that's kind of ingrained in this kind of tissue with our tendons, ligaments, all of that up here. All of those interconnect to create two joints, which is your tibia femoral joint right here, and then the patella femoral joint up here. Right underneath, we have that deep area called the meniscus, which really just provides a nice cushion for the knee. Some people can say, I've had a potential meniscal tear, and with that, you might be exhibiting some pain and symptoms. So this is definitely a nice kind of area that you want long-term for your knee. And over time, if that kind of degrades, we can kind of go into it, but people have to get potentially a total knee joint or something if it's further along. But with that being said, we can keep our knees happy and healthy. This might not ever be the case. It also creates a little bit of congruency within the knee, just because, just like a puzzle piece, the knee joint doesn't really fit with the femur all too well. So we need that stability of those ligaments. Like here, we have that lateral collateral ligament, LCL, our medial right here, kind of towards that medial knee portion. And in the back, we hear it time and time again. People have ACL tears, just kind of cutting, running, jumping, playing their sport, contact or not. And that's going to fall right here where it's kind of moving up superior and attaching onto that femur. And then right behind it is that PCL. So those ligaments are great. They're static structures. They don't have a great blood supply, but they really like to keep that knee stable. And once it's not, a lot of the time we kind of have those clicking, those clicking, buckling, loss of stability sensations in our knee. The thing that we can really kind of control a lot of the time, besides loading the joint and having kind of those tendons and the structures get stronger, is making our muscles stronger, right? So those dynamic stabilizers, specifically, we have like 10 plus muscles around the knee, but really emphasizing home our extensor mechanism, or the quadriceps. You start seeing it come here, has the quad tendon, and then we get down attaching to that patellar tendon, or if we want to kind of go in the weeds, base, because it's bone to bone, it's technically a ligament. But regardless, this is where we see a lot of the issues. So this is kind of where we're going to kind of put our eyes of focus today. But just consider your knee has a lot of muscular attachments. We want to get all of it strong when we're doing rehab, and we don't want to just only make one side stronger than the other, right? We want everything to be kind of a little bit more of that symmetrical, whether it's your hamstrings or your quads, the ratios of those, but they're huge in our rehab process. So just giving a little bit of love to always just getting those muscles stronger as we get older. With that being said, the biomechanics, kind of the movement of how your muscles, your bones, your tendons, ligaments all kind of work together starts here. We really think of the knee as kind of that hinge joint. Just like a door, it opens and closes, flexes it and extends. But we don't really take into consideration that does have a little bit of a rotational component. So with that being said, that tibia down here and the femur right here do rotate a little bit. And sometimes when you get into rehab, we really like to still focus on that movement that we don't do that much. And when we start rotating it, our knee's not used to it, it can get a little bit irritable. So kind of ingraining and starting to rotate that knee with some tibial rotation is really important for mobility of the knee. But it's getting a little bit in the weeds and we'll talk about it as we go. The other component is kind of that patellofemoral joint. The patella right here, again, it attaches to those muscles and it glides within this patellar groove. And if we go back, you can kind of see it up here. This is that nice groove, but it has to move. So when we bend, flex, and extend the knee, the patella is truly just like a pulley for that muscle to really engage, contract, relax as we move. So it's important that if some of those muscles are not, uniquely kind of balanced or kind of at the hip or at the ankle joint, we don't have that stability as well, that patella can be moved out of the groove and it can get a little bit of that irritability that we'll talk about a little bit later of why we see some symptoms in the knee itself. It doesn't always come from the knee, but it's coming from the hip or the ankle. So just here's just a brief little kind of clip just to see how that patella, femur, all of the tibia like to kind of move together. Let's see if it kind of shows if I play that first one. Click out of that. So you can see all those kind of ligaments hanging out in kind of that groove area, kind of underneath as it's bending and extending. And you can see even that little bit of rotation component that's happening too as we get into that. And then I like this side just because you can see how that patella is ingrained onto that trochlear patellar groove. It's kind of all in sync. Everything's attaching, creating that stability. And then you have that hyaline cartilage besides your articular cartilage with the knee, all making things feel kind of snug and nice. And over time, some of those things can be damaged and maybe cause some of that pain. So getting into now the kind of the weeds, I like to say, when we have knee pain, many of the times, like I said, we kind of want to just get through it. We like to mask it where we're putting on knee sleeves, we're taking medications, throwing on some like topical analgesics just to get that knee feeling a little bit better so we can do our movements, but it never solves the root cause of what's going on. So we kind of just mask it. And I'm not saying, here and there, it's not okay to mask. I wear knee sleeves when I squat. I do certain things when it gets heavy, but we definitely, as we kind of rehab or move through it, we want to address these problems because we don't want it to get worse or progress over time where then you can't do the movements that you feel capable of, but that you have a little bit of that irritability. It might start exacerbating and we don't want that. So I think the reason I put the weeds in here is because a lot of the time, root causes of knee pain, it's a symptom of kind of that hip or that knee, but also you can have, areas in the knee that get irritable or worn out or having kind of that the reason why you're having those mechanical symptoms. Like I said, if you have a meniscal tear, if some of the tendons are being overloaded, so you get a tendinopathy, loose bodies, meaning the meniscus kind of grows a little bit of that ball. You can feel like there might be a little bit of catching, locking due to those growth factors based on your age. You might having like I talked about like Osgood-Schlatters disease, or Larsen-Johansson syndrome. So those are kind of as you get older and you're going through puberty, you might be exhibiting some of those things. Compression of the bursa, so the knee has some bursas, your retinacular tissues, joint capsule, irritation, plica, like you name it. Like I said, we could really get into the weeds, what's around that knee that could be causing it. But we don't really need 100% certainty to say this is what's causing it all the time to help ourselves get better. So that's kind of the golden ticket there. With that being said, we have the next one talking about diagnoses. But before we think about that, think about why that might even come to be or come into fruition. Sometimes we have poor movement habits. So if you think about your technique or form, we can get away with it for a little bit, but then, it starts nagging at us a little bit. It gets after, and then we start seeing that we can't really do the things that we like. So we have to start fixing and correcting those before those neural kind of connections or patterns start making it worse. And we start loading even heavier within those patterns. And then that drives kind of that need to get a little bit irritable or angry. Mobility limitations kind of up and down the chain, like I talked about. If your ankle is pretty stiff, or maybe it might be something that it's loose, or even the hip is a little bit stiff, or it's feeling that can be a definitely a reason. So those pieces of the hip joint or the knee joint, but also muscular restrictions with those mobility limitations. And then strength, stability, and coordination, or the muscles turning on and off, is huge. They all play an integral role for making you feel really strong and resilient. And a lot of the time we're hanging on two legs everywhere we go. So the more that we can also train some single leg, and we'll get into that kind of with things that you can do to improve, it's going to make a difference. The final one I kind of want to get after is what we see commonly with people: overload and under recovery. There's a lot of factors of why our bodies under recover, whether it's sleep, nutrition, doing too much too soon, you name it. But when that starts to happen, we definitely have this capacity or this bucket. And if that bucket is kind of, we do everything in our activity, whether we walk, we run, we go to the gym, we go up 10 flights of stairs, you name it, we have, that capacity within our tendons. And if we start overloading it and it reaches that capacity immediately drops. That kind of bucket spills, we get a little bit lower, and then we kind of start reaching that pain. That pain starts coming on, it gets a little bit irritable. And then over time, we can't, again, do the same things, and we overreach that new bucket or that new capacity that's a little bit lower than it even was in the beginning before that injury. And it keeps kind of being this nasty cycle where you're just getting this, more and more irritation on the joint, or just the knee, because of that kind of constant overloading that it doesn't have time to recover on, and the capacity continues to drop. Usually when you're squatting, you don't typically have any traumatic knee injuries, like, a full quad tear with maybe like an eccentric low where you're lowering really slow. I mean, I haven't really seen it, but I mean, it's always possible for something to happen if you have enough load and maybe something goes a little bit off kilter that day. So, but overall, we're kind of talking about more of the things that creep up over time. So kind of getting to it, that idea that I talked about in the beginning, when you have diagnoses of the knee, a lot of the time we like to say we have a tendinopathy, whether it's at the patella or that lower portion of that knee joint, or higher where the quad attaches to the patella, or the quad tendinopathy, as we'll call it. That's that overload and under recovery that we kind of talked about at the end of this piece. But then as we go over into kind of the bucket of poor movement patterns, coordination and strength, and then mobility limitations, we start seeing things that are called like patellofemoral pain syndrome, IT band syndrome, potentially meniscal tears, or sometimes like a little bit of cartilage erosion on the patella. And then even OA as we get a little bit older, and that can be more genetic than anything too. So don't just think because I have this, I'm going to develop one of these. That's not necessarily true. It's just kind of where that bucket is kind of put. If you have some of those things, you could maybe potentially develop some of these diagnoses that we like to label things with. I like to kind of just give a note with this patellofemoral pain syndrome. If you're someone that's had that label or you've heard of it, it's really a blanket term that doesn't really definitively point to a specific reason. But we don't really, again, need this to treat. So when we squat, there's a tremendous amount of stress, especially as we load that squat. The cartilage that surrounds the kneecap and the femur, so kind of that patellofemoral joint that I was talking about in the beginning, if the knee doesn't start tracking because we have some abnormal pulling, what can happen is what's underside, or that cartilage that's underneath the bone, can kind of get a little bit more strained, and that's what's causing the irritability. It can lead to some friction, and like I was saying, some erosion that could lead to that irritability that you're feeling within the knee. So changing some of those movement patterns is going to be key. So with that, this is when you're at home and you kind of need to figure out if this is, if you fall into one of these buckets or something's going on. You can be your own detective a little bit by first just doing a nice movement screen. So if you record yourself doing a nice body weight squat, make some mental notes, do it a little bit like kind of slow motion and assess this. This can kind of globally help you pinpoint, oh, am I feeling a little bit in like my ankles dropping? Am I feeling a little pinch in my hip? Is there other things going? The faster we move through some movement, or the faster we move through a movement, sometimes we don't kind of sense what's going on. So slow-mo it, take some mental notes. Hold the bottom of the squat, like we kind of wrote on here, for a few seconds, return and repeat. Don't do it just once. See if it starts progressing or you're feeling your symptoms if you do a couple repetitions, or that if that volume increases. That definitely gives you some insight to what's happening. And then what you're going to look for, is there any pain, like I was saying, and how intense is that pain? Sometimes it might be just very mild, and once you stop loading the joint, it immediately goes away. You might have a low irritability, and that's a good sign. Definitely is showing that we can make improvements pretty quickly. And then you can look into kind of like your feet, like I was saying, does it kind of cave in, like we call it pronation, or kind of move in? And when that happens, sometimes that knee is going to move in with the ankle. So that's important. Does your feet rotate in a certain direction, or does one foot versus the other? And then kind of like I talked about, if your ankle's kind of caving, or does your knee kind of cave because maybe your hip feels like it's not as stable. So then it can't control that knee and it kind of starts kind of moving in. Another great option is from the back, seeing if you're shifting away towards one side. That could be because you potentially have that pain and you're trying to move away from that side and you're overloading the other, or there could be other reasons. So it's kind of like the chicken or the egg. We don't really know always what comes first if you have pain, so you kind of start shifting, but we definitely want to start moving away from those patterns so that you reload that knee slowly but surely. So that's where you can kind of start with that. If the first body weight squat feels pretty good, then start moving into a single leg. You can stand on one leg and perform this to whatever feels comfortable. If you want to do it to a chair, if you can do it like this woman here, that's pretty, that's like gold standard, pretty tough. You can try that. Sometimes doing it where you're like using some type of stability where you're holding and you're moving down, so you have that balance support. You can always try that. Again, repeat it 5 times. See if there's any differences that you can see. And this is really good because now you're not biasing by kind of doing that weight shift. You're really honing in, seeing what that knee that has been having the issue can tolerate. So again, look for those signs that we kind of talked about, and then look at kind of, is your torso doing something? So I know, like, is it, again, biasing? Is it moving away? All of that is important information, and that you could even bring to us, and we can kind of help assess and walk you through that if you're a little confused. So that's kind of where you want to start on that movement analysis. And then the second step you're going to do is just kind of look at your mobility. Like I talked about, up and down the chain is huge. So if we look at our hips, kind of external and internal rotation, these are really good guiding tools. If you take a photo or have that video on film, or even just notice that your, thigh is a little bit lifted here. So for instance, where I'm pointing, that person might be lacking a little bit of internal rotation. Here, we're lacking a little external. Just be mindful of trying to get your knee as far down as you can. And if you just can't go, that's going to tell you a little bit of something. So that's a great option. This test to the left is a really good option too, where you can just kind of pinpoint if you keep your pelvis. So you can't really see it here, but you would want your pelvis to feel like it's not rotating. It should be flat on kind of the ground. And then you are just going to bring that figure 4, almost like a stretch, and then let gravity kind of just push it down, or you can actively see if you can push it down. And then if one side has a little bit higher height than the other, where the knee kind of reaches the ground or the table, that's going to give you insight if you're lacking some of that mobility. Like anything, if you have a little bit of restriction, that might not be the whole picture, but if you're starting to see pretty big discrepancies, that's going to be a starting point for you to kind of address. The second one is moving down the chain into the ankle. So we call this kind of the 5-inch wall test. You don't want to perform this with shoes. So just take your shoes off. And then what you're going to do is bring that knee to the wall by having kind of a tape of 5 inches. Sometimes if you don't even have a tape measure, I like to use like my thumb. So I'll do my thumb And then I'll just take that like thumbs up, put it down, see if I can do that same thing without letting my heel rise off of the ground. So that's another option if you don't have it. But to have good ankle mobility, you would want both sides to not lift that heel, and you'd want that knee to touch at least 5 inches from the wall, or try to see if you can do that thumbs distance if you don't have anything. If mobility is not your culprit, or you're not feeling like, you have amazing mobility, some people are a little bit more hypermobile, then we might want to look at, are we stable? Are we strong? Are our muscles firing at the right time? And so this is a great tool because it's single leg too. So not doing both, and you're not biasing one side. You're going to see how many reps, or in this case, how long you can sustain that hold while keeping your hips up. You don't want the hips to drop. Set a timer, see how far you can, how long you can reach, or how many reps you can complete with kind of a nice cadence. And see if you're feeling any differences. Sometimes people feel it in their low back, or they're feeling a little bit in their hamstring. So maybe our glutes are just not coordinating and turning on. And so that we're getting different signals from other areas. And that's going to give a lot of information to what we want to work on. Finally, this is kind of a really good spot. So if nothing is really, out of all of these, nothing's really ringing a bell, and you're like, what do I have? What's going on? What you can also try is a load screen. So if your knee pain increases from squatting to doing just normal, just body weight squat, try to do that squat with a little bit of a tuck jump, just like this picture shows, on 2 legs. If that seems to kind of progressively, irritate that knee a little bit, and then you start doing like a single leg, which I don't really have here, but it's the same idea where you're doing this on 1 leg, you can be pretty confident that either the quad tendon or the patellar tendon is just getting overloaded and irritable, and you might be dealing with a tendinopathy. So try this out. It gives kind of the idea or the groundwork on how you want to perform it and how many reps. If it's just really taking you off, just do a little bit less. It might already be kind of the idea that this is where we're headed, and this is where we kind of need to rehab with more of a tendon rather than other kind of tissues leading the way. So with that idea of you did some detective work, you're maybe thinking it's falling in this ballpark or another. The knee's tricky because every day we walk on it. So it's a very loaded joint. So if any of that's kind of coming and kind of, if any of that is, where you're feeling some of those symptoms, or some of these are ringing a bell, then start moving into ways that we can fix it. Because maybe, like I said, even if some tissues are irritable, and we try some of these things, we don't necessarily need to pinpoint what structure or what's really kind of taking your knee off. We just need to start solving above and below the joint. And then we need some of those muscles firing appropriately. So if you realize that it's more of a mobility thing, I want you to try some of these out and see if they help. Okay. You can do kind of that nice external rotation that we have here with this. If your Faber test, or that one that was farther back here, seems limited, you can do a little bit of banded mobilization, where you're going to put that band right in your hip crease, and you're going to bring that knee in and out and kind of just hold it for a few seconds. Or if you're feeling like your 5-inch wall test or that ankle mobility was lacking, I want you to try that out. And one thing you can do too is just do a pause. So if you can do 2 sets of 10 repetitions with a 5-second pause, and then retest some of those things that make your knee kind of not feel so good, and it works, maybe we're onto something. So just something to consider there with some of the ways that you can start kind of progressively getting yourself back to moving. Second, if you're not feeling like mobility is your limiting factor, trying to improve that knee stability, you're going to start with that nice 4-step process that we wrote here. So create a good foundation, and we'll talk about that tripod foot. You'll do some glute activation, and then you're going to enhance that control, and then work into a little bit of single leg squatting, because again, too many times we're on 2 feet all day, and we need to work on getting a little bit more, loading the one side that's irritable, but like in a good way, I should say. And we'll talk about that. So as we move through it, the tripod foot right here, you're talking about kind of that ball of your foot right here, but we want to think about that nice triangle that we're having each section of this foot planted on the ground and not moving. We don't want one side moving, like kind of if you feel like you're, shifting that ankle in, this side might be what's moving the most, or that you feel like it's planted, but then you lose sight of this. So it's just trying to keep that nice solid foundation of 3 points on the ground at all times. And then once that's happening, I want you to try to like just do a nice 3 sets, 20 body weight squats, increasing that each time. If you can't get that range of motion, do the best you can with that body weight squat. And then if that starts improving and you're getting that nice foundation, you can add a little bit of load, but first just start with a nice body weight and really adhere to getting the neuromuscular control developed with something that you're maybe not familiar with. A lot of us don't even think about this, and this could be like the culprit right there, where we're just not engaging that foot fully and the ankle is kind of rotating in a little bit, which definitely puts a little bit more stress on the knee. So with that, if we move up the chain and we're not as focused on the ankle, because again, maybe you're really good at what this was and you do it all the time and it's still not making a difference, you can see if your glute's the problem. Like I talked about, you might feel a little bit more back and hamstring, and we want to make sure it's active. So try a little bit of these where you're doing 15 to 20 reps, not just 5 reps. I would like to say more reps with more seconds of the hold so that you can work on getting that burning sensation. If you do not feel like any of this is really like targeting the butt, one thing you can do is keep your yourself close to a wall and bring your arms over and by the wall and kind of press into the wall with your arms while simultaneously doing a single leg bridge. Sometimes that helps engage the core, solidify your back, and then you start feeling it in your glute a little bit more. So definitely just a tip or cue if you're not getting that sensation where you want it to. And then another one that we kind of always see to work on stability and single leg work is working the glute abductors, or those kind of hip abductors here. The glute medius is big, and a lot of the time we don't use it that often, and we're using other structures or other muscles. So here's a great tool where you can just do a single leg position, and then you're just doing that nice hip abduction. We don't always, like in PT, we don't always have to be fancy where we start. I know it's not always I call like the sexiest drills, are not always the most enjoyable, but they're a good foundation to start. And you want to get consistent with this because we just haven't. And usually that's why some of those knee symptoms start creeping, is because we take away and we do those big, strong movements, but we don't pay attention to the little things, and we don't wake up those muscles that just haven't been used or aren't being utilized enough. So with improving that knee stability, kind of going down that little kind of 4-step process, once you start doing some of these things, kind of creating that good foundation, now we can work on enhancing a little bit of that lower body control. So having that full awareness is huge. I love adding bands just because it allows you to see if you're not engaging the proper muscles when you're going down into either a body weight squat, a single leg lunge, a single leg, just a step up, you name it. You can kind of play around with this and add a band to a lot of movements to see where the ankle, the knee, and the hip are all leading. So with this, kind of wrote what you can do. You can perform, 5 reps of each of these sequences. You can have pauses, doing, anywhere up to 10 reps. Don't go too crazy where you have to do a ton of reps, because I want more of that pause position to just kind of feel that full control. But this is where you can start here, just to get a kind of awareness or proprioception to what your body is doing. And then finally, a lot of us don't do this because, again, we're on 2 legs all the time. We don't think about it. And then one side starts getting a little bit more of the brunt than the other, and we just kind of need to start retraining it. This is a little aggressive. So if you look at this stepping stool, it's pretty high. Start a little bit, shallower, of course, and then perform, we wrote at 15, 20 reps just for a little bit of guidance, but even starting at, a set of 10, if you can just start performing in your day to be more consistent, is huge. Just little kind of taps to kind of work on that single leg stability and strength will be great. As you've noticed, a lot of these things that we've shown are a lot of single leg stability. So you can train 2 or 3 things by just doing one exercise, which can get that bang for your buck out of doing a lot of control, muscular strengthening, single leg support stability, you name it. All these exercises kind of have it. and are a great place to start. And then finally, we like to say, don't stop squatting just because you're having a little bit of pain. Yes, we have to unload kind of the joints. We have to make, things feel better and quiet some of that irritability down. But there's so many modifications and progressions we can make, whether it's with load, whether it's with height, whether it's with, how you're, performing the certain squat. Like, we can kind of change it all to make you personally feel better about squatting so that you're not just completely going away. Sometimes when we do that and we quiet it down and we rest for 2 or 3 weeks, we start realizing when we come back, it's not going to change anything. We start loading that joint again. It almost feels maybe even worse and we're just not getting anywhere. We want to keep doing the movements that we love. We just have to find those nice modifications. And I could go on a soapbox about that. So I know I just keep babbling about it, but it's huge. So with that, some other options, if you're not going to load on that second one, like a box squat, this is a great option. That Spanish squat is nice because if you put that band right underneath your kneecap, what you start to do is you allow a little bit of translation for the joint. And sometimes it feels really nice. Start here with a little bit of isometric so that we're just contracting all those muscles that are around that joint, specifically the quads, and holding it for 45 seconds for 5 sets. What you'll do is you'll rest 45 seconds each round so that you'll, get that little bit where your muscles get tired, but then they can kind of relax, and then you'll repeat it. At minimum, if this is somewhere you want to start, try to at least hit 3. 5 feels like it's too much. You don't have enough time in your day, but you want to get this started. Minimum of 3, it's only going to take you, 5-6 minutes of your life, and then you can go on with your day and see if it's making a difference. After this happens, we can kind of load with that body weight squat. You might just start with the barbell, 10, 15-pound plates. I know it's hard to kind of leave your ego at the door if you're used to doing a lot of weight, but clearly that's overloading the joint right now, and we just need to quiet it down. So it's okay to take a step back. You're going to get back to the things you love, but in the long run, I think we always talk about short-term success that we do in rehab or therapy is going to lead to long-term, that longevity and doing all the things that we want to do without having that pain. So this is the first step. And then finally, like I talked about, doing some, single leg work, whether it's a rear foot elevated split squat like this, and we're performing quite a bit of repetitions. Maybe you're doing it at a tempo pace. So maybe we're doing it slow and controlled so that we can work on, making sure our hips in a good position, making sure our knees in a good position. All of the above is a great kind of first tool to progress us back to doing the squatting that we love. I think that's kind of, I could go into a lot here, but after that, we'll talk about a wrap up, but I don't have it necessarily on the slide. If you're somebody that does like to, jump and move and, it's not, necessarily the squatting, if we're dealing with some of those tendinopathies and things, that's definitely a progression for the future. And it's important. I think we should all, even if as we get older, know how to be explosive and have power and move within our day, because that makes the knee joint resilient. But after this happens and you feel more, resilient and less irritable there, that's when we can start progressing to a little bit of those jumping movements. If you're somebody that goes in the gym and you do, you're jumping rope or jumping on boxes, it is something that's going to always be with you. So we do want to get to that because a lot of people do have some similar symptoms with jumping. So this is kind of that starting, make it less irritable, and then we'll kind of move into more of those progressions towards jumping in the future state as that irritability calms down. A way to think of that too is if you start jumping and the next day it's feeling pretty good and you start on 2 feet, maybe then you start doing 1 foot jumping, just little, I like to call them pogos. If you go, a few days and you're like, it still feels pretty good, that means you can continue progressing into some of those jumping habits that you were back to, like box jumps or jumping rope or double unders and stuff, especially if you're more in that CrossFit community where you're doing all those activities. So, I kind of got on a tangent there, but we know that within our day, we don't want anything to stop us, whether it's squatting, jumping, moving, and knee pain definitely can be a limiting factor for most. So hopefully this gave you a little bit of insight of, where to start, where it could be originating. And if none of that's kind of working, that you can always come to us as physical therapists and that we got your back. So with that being said, here's a little summary of what we talked about. You can scan this QR code, but We always have availability for those 30-minute discovery visits. If you're just kind of seeing if we're the right fit for you at Thrive, especially, I think we really do a good job of getting you back to doing the things you love. Whereas some places, again, you don't have that same, one-on-one relationship. You don't have as long that you can spend. And we're always kind of making sure that you're getting you're getting the right, care for what you need individually. So with that, you can always visit us on our website. We have an Instagram, and then call us or email us. We're always available for you. So any questions?